So at this point, I think, I don't know. So as many of you know, Dr. Blumenkran has a very distinguished career in retina, and he is the creator of the Bio Institute at Stanford. He's currently the Professor Emeritus for Stanford and the eye department here, and we're wonderful to have Mark join us.
Thank you.
So now we have Dr. Levine, Dr. Goldberg, Dr. Blumenkran, Dr. Hu, and Dr. Huberman in this group here. So we can take some question. Let's see, we have any question here.
While you're looking at the questions, Mark, just want to let you make any comments. Thank you so much for joining this panel of experts.
Well, thank you. If you'll bear with me for 90 seconds or so, I had a couple of thoughts I wanted to share. First of all, I wanted to thank you, Joyce and Jeff, for putting together an absolutely spectacular meeting. I saw most of it. I couldn't be there, unfortunately, for some of the biomarkers, but I saw the rest. I learned a lot and really enjoyed it. I also wanted to acknowledge the very gracious efforts of a donor to enable this, and I'm very proud of Stanford for taking initiative to take that forward. Just a couple of thoughts. I've spent my whole life in clinical trial design in retina, and I've sort of seen everything over the years. And so I'm not sure that that's damaging or whether that's helpful, but you do come away with some impressions. So I thought I would just share with you, as a retinal specialist, my observations about some of the similarities and differences between this and some of the really common retinal diseases. If you look across the board at some of the really important blinding diseases like diabetic retinopathy and retinitis pigmentosa and age-related macular degeneration, they all start at the molecular level, the subcellular level, and at some point they become anatomic diseases with oftentimes even space-occupying lesions. So treatment, historically has evolved along the lines typically of dealing with the late stages, and then working backwards to the molecular levels, and then eventually to the regenerative and gene approaches. And I don't think this will be any different, really. I think the thing that is different about this disease is that it really is associated with a space-occupying lesion in a space-confined location. And that means that when you think about it, aside from really getting to the core issues as to what is the metabolic underlying genetic defect, if there is a genetic defect, you start thinking about maybe there is an element of space compression that's causing it. And in that way, it may differ slightly from glaucoma, for instance, although the end result is the same. And then how might you approach that disease if you were thinking about it both from the terms of the investigation and also the clinical trial design? And this is really a talk about trial design. So I would just say that there's a lot going on in the world now that really makes it possible to think about treating in a really creative way, even before you have full understanding. We knew nothing about the pathogenesis of VEGF and diabetic retinopathy or age-related macular degeneration, but we had somewhat effective treatments over the years. And so it speaks to the creative and the empirical side of looking at disease management. For instance, we have a lot of imaging data now, and we heard about that this morning. And we have the onset, of a really golden era, the early golden era of AI. It seems to me inconceivable that we wouldn't be able to take this longitudinal sequential data coming out of this work using fundus images, and particularly OCT, and then comparing that to the visual field changes that we're seeing, and using AI rather than sort of our traditional observational approaches to see how is it and when is it that patient starts to turn the corner. The other point I'd make vis-a-vis that is that we also have mobile tools and ways to be able to sample longitudinally with very high frequency over time. It's also possible we may use that. If we think about how you might approach that, one can imagine that when a neurally based vision loss occurs, there's probably a period of plasticity or reversibility that occurs. It's really hard to do that in glaucoma, to know exactly when that's occurring unless we bring people in all the time. But with this disease, if people were able to use these tools, which are cheap, easy to deal with, and so forth, we could really begin to understand the relationship between the disease anatomic progression stage and when vision's changing. Because Len, you spoke to this really eloquently about the issue of trying to design trials where you're looking to slow down the rate of progression. Those usually involve many years and many subjects and are very expensive. However, if you can approach diseases like this that may have some period of reversibility, and you can actually achieve visual acuity improvement, sample sizes go way down and time courses go down, because instead of trying to show a slight change, or maybe an inflection point, you actually see an inversion point in your trial. So those are just a couple of thoughts. I think AI is going to be important. I think this imaging is going to be really important. I think that potentially there may be some anatomic, and I'll just throw out a crazy idea. You know, people have written about this. I'm sure that it's poorly thought of, but people have talked about, can you decompress these acutely? I'm not a big fan of optic nerve fenestration, but there are some really precision tools that are available now that you could use if you wanted to, if you looked at this as something akin to a renal calculus or something like that. And is it possible to be able to non-invasively deal with those using, you know, OCT guided lasers and so forth, while we wait for something better to come along, you know? And so I just bring it up to say, as you develop these animal models, think about those types of things which have impacts on trial design, and maybe can give patients who are suffering from these diseases, you know, potentially an effective therapy, even before we perhaps fully understand the underlying pathophysiology. I'll stop at that point, but I just wanted to share some general observations from doing this, you know, in other related fields for a while, and ways in which it might be interesting to think out of the box a little bit. So thanks so much for the opportunity to comment.
I think those are all great comments, Mark, and really good ideas. The reversibility issue, you know, in my clinical practice, I haven't really seen a drusen patient who's reversed. On the other hand, any one person looking at a relatively uncommon disease doesn't see enough to know. And we also don't use kind of standardized measurements over time with any perspective basis to them. Maybe it occurs, and we just, if by only by collecting the data, we'd find out. And then in terms of the, you know, to be able to kind of destroy a calculus, like a, you know, whether it's by ultrasound or OCT laser, guided laser, or by chemical, I think that's a fantastic idea. It'd be great if we could duplicate this in an animal, you know, ideally a larger animal, to try it out. But, you know, it seems to make sense to me, you know, absolutely. You know, compressive optic neuropathies will, if they're taken out before there's been loss of the axons, there's a lot of recovery.
Pituitary adenoma comes to mind, you know, as an example where you have reversible vision loss if you decompress at a particular point in time, and after you miss that window of opportunity, you can't. And the question is, how long does that window stay open? And I think for different diseases, I think it's probably very different. But
yeah.
It's important to remember that these calcium phosphate deposits, they're really what make up our bone, you know, teeth and bone. And so it's not trivial to be thinking about it, you know, through some type of non-invasive method. Essentially, it's not as simple as, you know, sonicating a kidney stone or something like that, because the structure is so delicate and the energy that you need would be difficult. I love the remarks that you made, Mark, really thoughtful. And I thought that it may be useful to be thinking about the low-hanging fruit from all the great comments that you made as a starting point.
thank you, Joyce.
Great. So I guess we can take some of the questions here. We have, I guess I can group together. So this first pair of questions come from Dr. Terry Garvey. She has two questions. It's probably aimed for the neuro-ophthalmologists in the group here. So the first question has asked, any research on reduction of NAION risk from cataract surgery? And then the second question related to that is that our patients who have already experienced NAION, particularly useful for clinical trials, since they have very little to lose in the damaged eye. So first question have to do with cataract surgery and NAION. And second one, can this patient be good participant in trial because there's nothing else that we can do to help them right now and they already damaged? Len or Joyce, anyone?
Well, the cataract surgery one, it's a little difficult because recently, actually, the whole concept of how much does cataract surgery actually lead to an increased incidence of NION has become somewhat controversial. The second one, there's a large clinical trial that's ongoing, a 12-center phase 3 study that looks exactly at that, at patients who had NION who are being treated. And so, yeah, they're all susceptible. People want to enroll when they've very lost vision and they have risk of losing vision in the second eye, for sure.
Okay, that is great for those. Now, I'm reading here. So this question comes from Dr. Jesse Gale. It has to do with looking at optic dystrophy and compared to glaucoma. So it's indicated that optic dystrophy progress faster than glaucoma in kid, but then slower than glaucoma in adult. So the question has to do with, instead of visual field, can we see a role for electrophysiology testing to allow very rapid testing of the candidate drugs? So instead of visual field, let's say in children, because it's lower, can we use electrophysiology instead?
Well, I mean, it's a signal to noise ratio a little bit too, because electrophysiology has if in a sense the variability of the measure is higher, then it may not be as useful as a measure with a lower variability. In a kid, for sure, the variability is going to be fairly high with the visual field. How much the electrophysiology will be less or not, I think that's not well known for like things looking at a pattern ERG. I mean, I'll ask the other experts on who are in the webinar for listening at the pattern ERG, the multifocal VER, the full field VER. How much variability is there, and how does that compare to when you do visual fields and you look at the test retest reliability?
Yeah, I mean, the truth is we don't have a lot of data on other biomarkers like those compared to the amount of data that we have on visual fields. So we can do a decent job modeling how many visual fields and how many patients you would need for a clinical trial in a given disease. The other part that we don't have for any disease and any measure is, to what degree is there potential for a reversibility signal? And could that be detected with one or a different modality more effectively? And so the question had come up in the chat before around animal model to human translation. Maybe our animal models aren't that good either. And until we have something that actually, works at some level in a human, we're not going to really know how good any of these measures are, how good any of these animal models are. You kind of need one positive. You can't have all negatives from which to try to derive any understanding of why any given modality is looking negative so far. So these are important questions, but really they just belie the need for more research.
Yeah. Yeah, I noticed there's a question, it was bad for Andy, I think, from Evan Cameron. Have you tried stimulating both the recipient regions and regenerating RGC simultaneously? And does it lead to greater regeneration?
Yeah, that's a great question. We've just initiated that. So we only have results from 2 animals, which, cautions us against drawing any conclusions. We have this odd effect of when we increase activity in the ganglion cells and in the target region, we see far less regeneration than when we just manipulate the target region. So to just make it very clear, manipulating the target region leads to the most regeneration. Manipulating only the target region leads to the most regeneration. Manipulating only the presynaptic ganglion cells leads to the second most regeneration. And when you manipulate both, you get the result that you really didn't expect and that you didn't hope for, which is that you get less regeneration than in either case. And we don't know why that is, but we find it very interesting. And again, it's only 2 animals in that last case. The other ones, the ganglion cell regeneration and the target manipulations alone, we're confident in because we have at least 10 animals in those cases. So this is important clinically because, there are a couple groups, one in Germany that's been looking at retinal stimulation as well as visual cortical stimulation, either separately or simultaneously. I don't want to speak for him because I don't know, but a conversation with Joel Schumann led me to believe that his group and some groups at NYU might also be exploring these non-invasive ways of stimulating retinally through VR-like or VR apparati, and then also devices placed on visual cortex to amplify visual cortex activity. So lots to think about clinically, even just when we're thinking about these things non-invasively.
Great. Another question comes from Dr. Susan Altman here, and it's asked that it sounds like some people have considerable vision loss in terms of optic extrusion, but that most patients fare well. Is this your general observation? And this for the clinician is so Joyce, and everyone.
I'd like to get a survey because there are quite a few neuro-ophthalmologists on the webinar still, and it'd be great to hear. Before last night, my wife's also a neuro-ophthalmologist, and I in preparation, I thought that question would come up, and I said, what's your general impression? And what's my general impression? How many people with drusen actually have, significant visual field loss? And we both guessed around 5%. I don't know what everybody else's opinion is because obviously it depends on who gets referred to you. But Joyce, we have lots of, I don't know if Mark Moster's still on the call, Larry Froman, Ms. Helen Danishmeyer. There's a whole bunch of ophthalmologists. It'll be interesting to see what people think.
Joyce, you want to start this thing?
Yeah, I think the number is probably at least 5%. And the narrow study that Stefan Hammond is doing is also particularly relevant because it's a multi-institutional study looking at all patients with ischemic optic neuropathy to look for the presence of drusen. So, kind of like thinking about drusen as contribution to other causes of vision loss like NION. I think the important thing to remember is even if it's a small percentage, there is potentially something like 2% of the general population that have optic disc drusen, potentially more if we have better imaging modalities and a better understanding of what the hyperreflective lines might mean. Are they underlying some kind of risk factor? And then to those who lose vision, they tend to at greater risk of bilateral involvement. And so it's a very important population and important cause of vision loss. And then finally, I think whatever we learn about optic disc drusen will absolutely be applicable to glaucoma, many of the optic neuropathies. And so in that way, I think we have a unique opportunity to be pushing for an orphan disease that has a way to impact the world.
Oh yeah, and not to say that just because the numbers are not particularly large, it doesn't mean it's not critically important, because it's not something we can't do anything about, and those who have it, they lose significant vision. I noticed Helen texted or chatted in, agree 2 to 5% in my experience.
So we have also Dr. Bradley Cass and Dr. John Kellner also agree that 5% have significant visual loss. Okay, so that's a good number that we learned from this optic disc drusen meeting. We can tell our patient about 5% of you will have significant visual loss. Okay, this is an important point. A question comes from Dr. Wayne Farmer, who asked that, I don't recall seeing any gene therapy mentioned in the treatment section of today's conference. What could be done to interrupt the change of genetics and chemical events that produce drusen? Jeff, you want to take on that question?
I'm sorry, could you just repeat the question part of it? I heard the intro
Sure.
part.
Dr. Farmer asked, I don't recall seeing gene therapy mentioned in the treatment section of today's conference.
Yeah,
what could be
it.
done to interrupt the chain of genetics and chemical events?
Yeah, so I think there's two important components to that question. One is if we could discover the genes that are causing the pathology, as was discussed in one of the sessions on genetics this morning, then potentially we could use gene therapy to interfere with those genetics and prevent the expression of the disease, sort of cut out the underlying genetic pathophysiology. The other, and so that of course depends on discovering that. The other approach would be to use gene therapy just as a convenient way to deliver therapies that might not be specific to optic dysdrusen, but might generically help retinal ganglion cells or retinal ganglion cell axons. And that's being very actively pursued. The fact that we now have approved gene therapies for use in human eyes and many gene therapies being tested for other diseases has really opened up a panoply of opportunities, including the use of the same kinds of viral vectors to deliver genes, even as I say, if those genes aren't specific to ODD, but could just help protect or restore or regenerate retinal ganglion cells. Some of the genes that I mentioned in my talk would be very good candidates for that. Andy Huberman, I noticed, and Yang Hu also talked about some specific genes they've been studying that would be great candidates to move forward into that pathway towards human translation. So I think it's a very hot topic, very, very important area to keep going down.
Great.
Yeah,
One
if
of
I
our
could-
patients, Ms. Anita Patton, just asked, so curious as a patient, what is considered significant visual loss, vision loss here? When we talk about vision loss, are we talking about the 5% that is this going to be like at the legally blind level of 2200 or worse, or what level is this of the vision loss?
Well, the loss of the central vision luckily occurs late, but if the constriction, my patients who are most disabled visually from their dysdrusen is when they have so much constriction that it causes them to have difficulty just even walking around, or it limits driving or the safety of driving, or sometimes legally limits the driving. And so, I think that it's the same as if in glaucoma. I mean, in glaucoma, you can lose fixation and go completely blind, as you can rarely in dysdrusen, but just losing significant peripheral vision, especially when you're young, is a significant deficit. And I think that's my personal experience.
So we're coming up toward 5 o'clock, and I wanted to ask one final question to Len, Mark, and anyone who wanted to add. Len, when you, me, and Jeff were at the glaucoma workshop many years ago, I remember you gave a really beautiful summary of what it would mean to do investigator-initiated multi-institutional studies. I was wondering if you could comment on the feasibility of that, because I understand, as Kwan pointed out, that it's difficult to be doing treatment, especially specifically related to a drug in this condition. But what about if the people who attended this meeting decided that they wanted to get together and do a study? Can you talk about that?
Well, sure. I think it's a fantastic idea, Joyce, and it's very applicable. There's one ways to do it fairly standardly using the same framework as in a clinical trial, a multi-center clinical trial that's put on with, let's say, NIH funding or through industry funding, and use that same framework. The other approach, which is becoming much more popular in the last 2 or 3 years, is to do a pragmatic clinical trial, which is based on where you have not as strict inclusion-exclusion criteria, and it's all based on practice-related areas, but it still could be randomized. And so you don't do it as strictly, but you can enroll far more people. And it gets back to the whole concept of what's called large simple trials that I think was back in Cambridge back 20 years ago. This concept that if you had enough people, you can, in a sense, and it's still randomized, you can make up for the fact that you're not as strict with the criteria. And I think that would be a perfect opportunity for all of us on this webinar, but also our community to do something like that.
Yeah, I think that I'm a strong proponent of the investigator-sponsored trial, because it's really based on our interest, and many of the major phase 3 clinical trials start out with the phase 1 multi-center or single center of investigator sponsors. So I think that if you can do that, that will help to move the field forward significantly.
Terrific. I think there's a definite interest in that. So I just want to wrap up by thanking all of our terrific speakers and panelists. I think I've learned so much today, and it's a beginning of a wonderful conversation and investigation in an important disease. I also want to thank the people who have been behind the scenes helping us all day. So these are their pictures, and I would love for them to unmask themselves just so they could be thanked by us live. There you are. I also want to thank the generous donation that made this meeting and this research possible. Thank you, everybody. And it's amazing that during COVID-19, we could have such an amazing, world-class meeting like this. I think some of it's maybe even better than in-person meeting. What do you think?
Well, I want to add one note of congratulations and thanks to Joyce, who together with this team has put together an unbelievable day. And I was going to make actually a very similar comment, Joyce. I think we have had considerably more interaction and participation from the audience than we would normally get at an in-person meeting. And in part that was because the technical, carrying off the technical components went off so smoothly all throughout the day with the chat, the Q&A, bringing people into the panel discussions, having a wonderful, wonderful audience beyond the speakers and panelists. And so just thank you everybody for participating. And Joyce, thank you and congratulations to the whole team for putting together an absolutely fantastic day. And we'll look forward to a lot of great work getting done in the year ahead. And that will allow us to look forward to what we will hope to see next year, the second annual ODD meeting. So thanks very much.
Thank you.
Thank you.
Please answer a few questions for us. This will help us better plan for our future meeting.
And now we go out to dinner.
The only thing that we're failing to figure out so far is how to distribute to all of the speakers' homes an equivalent bottle of wine that can all be opened and poured so we can toast at the end.
Okay.
I think we're just missing that technology right now.
Yeah, it was originally supposed to end triumphantly over wine, as Jeff described. Next time.
PP, post-pandemic. Great. Well, thank you.
Right. Well, Len, thanks for coming on. It was really great seeing you throughout the day as always. And I think this certainly, germane to our other conversation, speaks to how well a conference online can be done.
Yeah, that was great. It was really good. Well,
Very reassuring.
thanks for Joyce and Jeff and everybody for doing this. It was really wonderful. I had a great time. Take care, everyone.
Thank you,
Thank you, everyone.
Mark.
Thank you so
Share
much.
the poll.
Thank you.
People seem to enjoy it, so enjoy the poll results.
Okay,
Thanks,
great.
everybody.
Take care.
All right.
Bye-bye.
Andy, thanks for coming on. Oh, he just jumped off. Mark, thanks so much for coming on.
Thank you, Jeff.
Great
Thank you
ideas,
all.
Mark.
Nice
Really
to see you
appreciated your comments there. That was very great guidance,
Very-
for how
Yeah,
we think
that was
about
really
it.
good.
Yeah.
Take care.
all. All right, take care, everybody.
Care.
Bye.
Bye.
Bye-bye, everybody.